if I don't get it done by 3, it'll be done by noon tomorrow, but I should be okay to get it done by 3. So, with that said, okay, so we're gonna start off with ECGs today, and then we'll finish up cardiac next week, and then your test is in 2 weeks from today. With that said, in the beginning of ECGs, hopefully this is all review. So we're gonna go through it really quick. It talks about anatomy and physiology. If you have any questions, you can always ask. However, again, it should be review. So let me just preface by saying this. So when we're talking about ECGs, we're talking about at the bedside with 3 to 5 leads. Okay? When we're talking EKGs, those are the 12 leads that they do when coming in within 10 minutes of chest pain into an ER. They have to have an EKG, unless EMS, of course, 2 brings it in. But however, it will be done within 10 minutes of a chest pain certified facility. So, starting off with that. 1, we know that it's 2/3 of the sternum. It's in your 5th intercostal space where the heart is located. With that said, we have the layers, the 3 layers, your parietal, your visceral, and then your pericardial cavity itself, which contains a lot of lubricant fluid. We'll talk about the pericardium a lot more next week when we talk about pericardial infusions and then cardiac tamponade, which you'll see the ECG reading of a cardiac tamponade, but we'll go in more detail next week. So here's pictures of what that looks like. Again, hopefully this is our review. Then we have the heart wall layers itself, the epi, the myo, and the endo. So the endo means within, so it's actually the lining of the heart chambers and the vessels as a whole. We should already know that there's 4 chambers or 4 components, however way you want to look at that, of the heart. Very important to remember about when we start to talk conduction. The right atrium to the right ventricle plays a big role. Okay. Then we have our valves. We'll touch on these, but just for review of where those are located. If you don't remember, please review it as a whole. So, when we're talking about cardiac circulation, here is a fancy way written out, but I want somebody to tell me how a blood flow or a cardiac cycle circulation happens. So who wants to do it? Yay! Any volunteers?
Like how the blood flows through the heart?
Yes,
It's
please.
the right atrium, right ventricle, and the lungs, left atrium, left ventricle.
And then out to the rest of the body. Perfect. With that said, 1 major role in left ventricle to get that oxygenated blood to the rest of the body. So keep that in mind when we start talking heart failure. Okay? Cardiac cycle. As this blood flow is happening, that is a roundabout way of what Mike just said, and a roundabout way a cardiac cycle itself. So, cardiac cycle is 1 heartbeat. So these are definitions that you should be familiar with already. Again, review. We're going to touch a little bit more. Systole, which is the phase and the ventricles contract. Then our diastole is when they should relax. So that's always why we say that bottom number should be lower, because it's a relaxing state. If it's higher, there's something going on. Heart rate is the number of cardiac cycles in that 1 full minute. And then ejection fraction. So controversy here with the normal versus different resources. So our textbook says it's 50 to 70. We like to see patients at least in the 70s. In some of the other literature that you will see it referred to as 60 to 80. It's important when we're talking ejection fraction, because that is the amount of blood coming out of that ventricle, so injected to the rest of the body. So we're really truly looking at that left ventricle. So again, talks about heart failure. And if we have an ejection fraction less than that happy world of 70 and less, then that tells us that there's something wrong with that ventricle. Again, heart failure with a decrease in function. We already know that cardiac output is 5 to 6 liters per minute, and we know that it correlates to the urinary output of 30 mLs per hour. Important when we're talking about patients that undergo cardiac surgeries, which we will come next week. So we should already know conduction is SA node to the AV node to the bundle of His to the Purkinje fibers. So here is an illustration, which I love it, I can hug it and kiss it, that correlates the signals with the SA to the AV and what our one self beat is doing when it comes to ECG monitoring. So we'll just let that play out for a second so you guys can watch it. I'm sure I think my head's in the way. I'm not that tall. Okay. So we see in the world of our ECGs, we have a couple of things that we need to look at it. We have one, a P wave. As we see from the illustration of what you already know, P wave equals what? Activity. Atrium, right? Atrial. So our atrium, right atrium to be specific. Our QRS represents what? Our ventricles. That's where you see our ventricles, which we'll point out here in a second. And our T wave is the last little hump, right? And that's showing that no activity really is going on. It's kind of like the heart taking a breath, okay? So we're just gonna put a sigh, because that's what the heart's doing, is sigh. So when we see anything going on in the T wave, like a mountaintop, a peaking, or an introverted, that tells us something's going on more. And if you're lucky enough to see a U wave usually represents, which would be after the T wave, U wave represents low potassium levels. You probably will be less likely to see those. If you have, that's fantastic. If you haven't, you'll see those PVCs that we mentioned when we were talking electrolytes. So, the thing that we need to remember though, as we go along, is we have intervals we have to measure. So we say the PR, QRS, and then the T and the P that we mentioned, and then we're gonna go along here. So, a normal beat, you see the P waves in green, you have the Q, the R, the S, and the T, okay? You have segments that go along with it. We have a PR interval, we have our QRS, we have an ST segment, QT interval, and then our PR segment. So, first things, when we identify and come to interpret ECGs, one thing that we need to realize is when we're measuring, that's how we get numbers to interpret. So, when we go along and we're measuring the P to the R, if you remember, even though it's called the P to the R, we're really measuring it to the Q, to the start of the Q, because if it was measured to the R, it would be in there. So we're measuring the PR interval, which is really P to the Q, okay? There's a measurement that we'll tell you in a second. Then we measure the QRS, which is illustrated in these colors, but we start with the Q and in with our S, and then our T wave. If you ever heard of a STEMI or an ST elevated MI, that's what we're looking at. Because for those of you who watch football, or whatever else, because that's my world right now, line of scrimmage. You notice that everything is on the line of scrimmage, which everything's on that line, right? So if we see that the QR or the R is introverted, it doesn't really mean anything. Sometimes it's bleed placement, sometimes it's how big the patient is. But we want everything to be pretty much on that line of scrimmage. Like I said, if this is flipped, that's okay too. We don't want anything that's elevated above the line of scrimmage, and we don't want anything that's depressed. And we'll talk why as we go along in the next 2 weeks. Okay? Everybody okay so far? Okay. So, first and foremost, the first thing that you're gonna do in an ECG to interpret the rhythm is number one, is find out if it's regular or irregular. So the question comes into play. If it's regular or irregular, how are we gonna figure that out? In this class, this is just to get your feet wet in the pool with ECGs. When you go on to your professional world in your careers, and you go to ICU, cath lab, wherever you extend to go, there's gonna be a whole 4-week class you have to take. This is just to get you the basics and to move forward to get you to that point. So, with that said, I should have prefaced by saying that. However, we don't have you using ECG or EKG calibrators. You can simply look by the naked eye. So the first thing to find out if it's regular or irregular is one, to look for your R waves. And so this rhythm is not normal sinus. Let me just preface by saying that. That is not normal sinus. The reason that I didn't fix it or I kept it is because I like the way it points things out to you guys. So this is actually a sinus bradycardia, okay? So let the record show there. So don't look at that part, just please look at the strip itself. So we're measuring in a 6-second strip. So every ECG interpretation that you do is within 6 seconds. Okay, that's first and foremost. So this is a 6-second strip blown up really big so you guys can see it. Is we're measuring R waves. So our goal is to make sure that when we measure, you take a piece of paper, you would take your calibers once that comes to time, and you're wanting to make sure that the R waves match. So these two, and then you would flip it over to here, flip it over to here, and flip it over to here. So that tells you that the R waves, it's a regular rhythm. So that's the first thing that we do. We'll see irregular here a little bit later. The next thing that you're gonna do is find out if you can identify P, Q, R, S, and T. So, we wouldn't start with this per se because we don't know what's in front of it. We assume it's a P wave, right? But we can't assume. So we look to this. We can see the P, the Q, the R, the S, and the T. Okay, so it's there. So that is one self-beat. Perfect. So then we will do is we would find out the PR interval. We would measure. And how we measure is we would take the start of a P wave, which looks great right here to start on this dark pink light. Every little box that you will see, it's represented by a dot. It's actually a box. If you would draw lines, you can see boxes. But they're actually dotted for that box. It's 0.04, every little box. Okay? So you would measure then, how many boxes does this PR interval measure to get me to that PR interval? However, again, not going to the R like it says, it really should say the P to the Q. So we're gonna measure 1, 2, 3, 4, ends it right at that start of that fifth. So 4. So 4 times 0.4 is what? 0.16, right? So you don't just say 16, you would say 0.16. Kind of like the math rules with that 0 in front. So 0.16. Normal PR is 0.12 to 0.20. So that falls within that normal. The next then we would measure is our QRS complex. That's the next thing we measure, is our QRS complex. Same thing here, we start with the Q. Get to that one. 1, 2. 2 boxes. 2 times 0.04 is 0.08. So normal of our QRS is 0.04 to 0.12. So that is normal. So that falls right within that normal range. Number 5 is then we measure heart rate. For purposes of this class, all you're going to do is count the R waves and multiply it by 10. So again, knowing that this is not normal sinus, we cannot count this as a full complex, so we're not going to. We would count 1, 2, 3, 4. And even that's a little shabby because it's over. So if you really look at this, it's more like 40s, we can say, apostrophe S. So 40 apostrophe S. As we go along, that's how we're going to interpret all these. So you'll see a trend. So in normal sinus rhythm, a heart rate has to be within 60 to 100, okay? So it's regular, everything's identifiable, the PR is within normal, the QRS is within normal limits, and our heart rate is between 60 to 100 beats per minute, okay? So, how you're gonna remember the PR interval, hopefully this helps, and the QRS, is I have an uncle, or you have an uncle, or an aunt, or a cousin, or a dad, a grandpa, whomever, works at the mill or worked at the mill, okay? And their shift is 4 to 12. But in order to get there to their shift, they had to take 12 and 20 to get there. Because you have to get the PR before you can get the QRS, right? So you have to drive the road before you can start your shift. So hopefully that helps in the numbers to remember. Even though it's 0.12 to 0.20, of course, and 0.04 to 0.12, okay? So whether I have an uncle or you have an uncle, it doesn't matter, but let's pretend that Dee Dee does have an uncle that worked there, and 12 to 20 to start the shift, 4 to 12, okay? So here, first thing we're gonna do, and I'm gonna ask you, is this regular or irregular? Regular. Is every P, Q, R, S, and T identifiable?
Yep.
For all of them, right? So yes. So our PR interval looks to appear to be what? 0.16. There's 4 boxes. Looking specifically at that one, you can definitely tell that. That one too. Then our QRS is about 2 boxes, so that gives us 0.08. And then what is the heart rate? 90s. Okay? So that, by definition, makes this normal sinus rhythm. Okay? Makes it normal sinus rhythm by definition. So we have to identify and measure and do all of that before you can move forward. So we have to understand that this is normal sinus rhythm based on regular, identifiable, normal heart rate within between that 60 to 100. Okay? Good? Moving along. Now, regular, irregular. Regular. PPRST, all there?
Yeah.
Yep. PR interval.
It's so hard to see. Maybe 10.
I think it could be almost 4 or 5. Pretty close. So it's still within normal, right? Our QRS.
2.
Looks pretty close to 2 again. So 0.08. And then our heart rate.
40.
40s. Yep. So this is sinus bradycardia. Do you notice it doesn't say normal sinus bradycardia? Do you know why it doesn't say normal? It is not normal to have a heart rate less than 60. That is why we just don't throw that word out, normal, willy-nilly. It's only when the heart rate and all these things are identifiable. When it's regular, it's all identifiable within normal, and the heart rate's between 60 and 100. That makes it a normal sinus rhythm. Here, this is sinus bradycardia because all of this checked off, but the heart rate's less than 60. Okay? Yes?
Explain to me how you find the heart rate. I'm sorry.
You count the R's. So there's 1R, 2R, 3R, 4R,
Okay.
times 10.
Gotcha.
Yep, and then you just 2 apostrophe S. Because technically it's probably about 48. But for this purpose, we're just counting the R's. Yep, and multiply by 10. With apostrophe S. Okay, good with sinus bradycardia. Now we have sinus tachycardia. Well, we'll see. I don't know, maybe not, right? So is it regular, irregular?
Regular.
Perfect. PQRS and T is identifiable?
Yes.
For sure. PR intervals? Yes, they're there. What's the number?
That's too hard.
About. It looks like it's another 4. So 0.16. How about the QRSs?
0.08.
Yeah, that looks like it's pretty much only about 1 box.
1 box.
So yep, 0.04. Kind of hard to see. Then we have a heart rate of what?
110. Tens. 1, 2, 3.
120.
120s.
120.
120s is probably good. Yep. So we notice that tachycardia then is identified over 100, right? So now we have everything else, again, regular, identifiable within normals, and the heart rate's over 100. So we make that a sinus tachycardia. Okay, moving on. SVT, supraventricular tachycardia. What is the drug of choice for this rhythm? Adenosine. Yes, remember from pharm, acute roofer was den and adenosine. How do we do this? Do we just push this slow?
No, you push it fast and follow the saline flush.
With a rapid saline flush of 10 mLs. Yep. But that first we would have them bear down. So technically we can it's regular, right? Anybody object? No? Regular? Good. Can we see PQRS and T's?
Mm-hmm.
Yes. PQRST. Faster the rhythm, it could overlap. Michelle, you have a question?
No, I'm trying to see the little boxes.
Okay. Then we have PR intervals. Pretty short. They look like they could be about 3 or 4. So that's within normal. QRS with a normal heart rate.
170s.
170s. A little bit, but 170s. So, moral of the story is SVT is a greater heart rate of 160. Times we see these patients. During the summer, mowing grass, when they're push mowing, they get overheated. Roofers that are up there getting overheated. And then those patients who have one bout of SVT are more common to get it again. So the first thing we do is have them bear down. Like they're having a bowel movement, they're gonna take a big deep cough, they're gonna blow into a straw. And then adenosine is a drug of choice, rapid IV push with rapid saline. Yes, Robert?
Is it 170s because that first QRS isn't, like, the
Correct,
P
it's
wave
not
isn't
full.
complete? Okay.
Yep. Yep, it's gotta be full. Full complex, this is what you count. Was there another hand? Melissa, did you have your hand up? No.
No,
Kristen?
so the only difference is, heart rate, or you said some, like the P was shortened, or something else, or something, just the heart rate?
Yeah,
Anything?
no,
Okay.
yes, yeah, no PRs or short, we don't worry about that.
Okay, just.
Yeah, it's the heart rate is greater than 160 per definition. Per definition, what greater than 160. All right, we're good. SVT, adenosine is a drug of choice. Since we're mentioning medication, there is an emergency drug handout for review. I would be sure to look at that for the next 2 weeks and for testing purposes. Please and thank you. Now we're moving into sinus with a first degree AV block. So one thing that happens with a first degree AV block, if you notice, it still says sinus. So you should automatically thinking that it's regular, everything is identifiable. It's got something here, right, that's going on in the heart rate. So with that said, if you would notice that yes, it's regular. 2, it has P, Q, R, S, and T. But if you notice something different, the PR is elongated. So what that means is it's greater than 0.20. So if we look at one to measure, we can go ahead and start here. 1, 2, 3, 4, 5, 6, 7, 8. 8 times 4 is 0.32. So that's greater than the 0.20 that we originally talked about. So the difference between a normal sinus rhythm and a sinus with a first degree AV block is the PR interval is greater than 0.20. That is the difference. Because everything else plays, everything else is checked. It's just the only thing is different is our PR interval is greater than that 0.20. Okay? That one's a fun one. But we get more fun as we go along, yay! Second degree AV block type 1, also known as leaky back. So when we're looking and doing our game here, we can see that the R waves are regular, but holy crap, where they're supposed to be one, it drops. So if you also notice something about this, so it's technically irregular, right? If you notice something else about it, here's a P wave, right? It's got a P, Q, R, S, and T. But this P wave is awfully far from the Q, R, S, and T. This one looks even further than the P, R, Q, R, S, and T, and P. What happened? It dropped to Q, R, S. So it gets long, the PR gets longer and longer and longer, drops to QRS. That is by definition what second degree AV block, Bobitz type 1, parentheses, winky back, elongates and drops. The PR elongates and drops. As we see here, short, little longer, rut row, it drops. Okay? Everybody see that? Good? Okay. Now, with second degree Mobitz type 2, if you notice, we have a P wave. That PR looks the same. And then row, we drop a QRS. So, with Mobitz type 2, second degree Mobitz type 2, we have where the P waves are consistent, then drops a QRS along the way. Because you see that. Here's a P, here's a P, here's a P. Should be very consistent, but row, the ventricles aren't responding for whatever reason. Same thing, consistent, drops a QRS. So the P waves are consistent and drops a QRS. So just in discussion purposes, our favorite word weeks ago, right, was perfusion. So if we already know that it goes SA to AV to the bundle to Purkinje, right? We're going atrium to ventricle. What's not happening when we have second degree AV block 1 and second degree AV block 2? Perfusion. That's a word you guys should have yelled out at me. Perfusion. These patients are not perfusing. Okay? Then we move in to third degree AV block, also known as complete.
I have a question about like the winky block. Since like the PR interval is different for each one, can you measure the PR interval?
You really can't.
Okay.
Yeah, I mean you could. You can say, okay, this one was this one, there's no
You have to
reason.
do it
Yeah,
individually.
yeah.
Okay.
Yeah.